Hi, good afternoon.
So we are good to start now. So with all your due permission, can we begin? Hello.
Perfect. Please start.
Uh, Thank you so much, sir. Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With great pleasure and honor, I would like to welcome our speaker, Doctor, for today's session. And he is none other than a very renowned internal medicine, Dr. Kumar Prafull Chandra, sir. Sir is MD in Medicine, DFID, CMC Vellore, MSc in Advancing Diabetes Care, UK, directed the Department of Internal Medicine and Diabetes Care at Health City Vistar Hospital, Gomti Nagar, Lucknow. Sir is also the director of Chandra Diabetes and Obesity Clinic at Vijayanta Khand, Gomti Nagar, Lucknow. With the help of Sir, we'll be taking a close look on today's topic, which is interpretation of thyroid function test. Before moving on to today's session, let us have a brief look on what the topic says. The results of thyroid function test are always interpreted in light of the clinical status of the patient and categorized as hypothyroid, athyroid, or hyperthyroid. It is important to be aware of these conditions and or disorders as they determine the pattern of further investigation and management. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Thank you very much, Batul and IJCP MedTalk for giving me this opportunity to talk about interpretation of thyroid function test. Well, I've been introduced in a good way by my host. Thank you once again for that. So today's topic, what we are going to talk about is interpretation of thyroid function test. There are a few simple things that I want to say. When we talk about thyroid function test, its interpretation is usually straightforward. However, there are certain conditions in which we may have unusual pattern in thyroid function test. And when there is unusual pattern, we need to correlate them with the clinical picture. Because whenever there is conflict with the clinical picture, a reassessment with the clinical context is able to explain the thyroid function test. And there are certain conditions in which thyroid function test really does not correlate with clinical function, and that is what we call discrepant thyroid function test. Here we need to understand what are the potential pitfalls which can lead to misdiagnosis and inappropriate management. So that is how we will try to understand today's topic. So before we talk about interpretation of thyroid function test, a little bit recap of the physiology, how this thyroid hormone synthesis is regulated. So well, from hypothalamus, thyrotropin releasing hormone is released. It goes to the pituitary, and in pituitary, thyroid stimulating hormone is released, and this gives positive stimulation to thyroid gland from where thyroid hormones are released. Now, in turn, it has got negative feedback on the sources. So when thyroid hormone is released, it has got negative feedback on the anterior pituitary, and thus through its negative impact on thyroid stimulating hormone is decreased. Once again, when adequate thyroid hormone is released, thyroid stimulating hormone comes down. Thyroid stimulating hormone in turn has got negative feedback mechanism on thyrotropin releasing hormone. So this thyroid function remains under a tight control with positive and negative feedback, and that is what we call thyroid equilibrium. And thus body, each and every cells of the body gets thyroid hormone, which is important for the normal metabolism of each and every living cell of our body. Now let us move forward. How is this influenced? How thyroid stimulating hormone is influenced by thyroid hormone. So it is called a log linear relationship between free T4 and TSH, which means that relatively small change in free T4, even within the normal range, leads to marked excursion of TSH. And that is what we can see here. Slight change in the T4, you can see these are the normal limit, and this is TSH ranges. So TSH varies greatly. So TSH is the most important barometer of thyroid function. Since it is very sensitive, even slight change in thyroid function will get reflected into the TSH. Thus, TSH becomes the most sensitive barometer for measuring thyroid function. So whenever you see a thyroid function test, the first thing that we need to see is where is TSH. With every 2 to 3 fold increase or decrease in free T4, TSH level decreases or increases by about 100-fold. That is how it is important. Now, certain conditions are there where this feedback mechanism doesn't work well. I told you that TSH is the most important hormone to know about function of thyroid. But there are certain conditions where TSH alone might be misleading, which includes central hypothyroidism, which means that TSH is being secreted in less amount from the pituitary. So anything that is happening, that leads to abnormality in secretion of TSH, either increased TSH or decreased TSH, which is not under the dynamic feedback mechanism of T3 and T4. In those cases, measurement of TSH alone will be misleading. Examples: central hypothyroidism, non-thyroidal illness, resistance to thyroid hormone, TSH secreting pituitary adenomas, and another condition is recent treatment of thyrotoxicosis. What happens in that in thyrotoxicosis? Um, Thyroid hormones are increased, and that's why TSH is suppressed. When you start treating with thyroid hormone comes to normal level before TSH comes to normal level. So TSH remains suppressed even when thyroid hormone level have returned to the reference ranges. So these are the conditions where TSH alone may not be helpful. Now, let us move forward about interpretation of thyroid function based on TSH. The first thing is that when TSH is normal, let us consider that thyroid function is normal. For the time being, we will discuss about variations later on. So when TSH is normal and T3, T4 are normal, we consider it as normal thyroid function. Now there are two conditions. Once TSH is high or TSH is low. High TSH will occur when there is decreased secretion of thyroid hormones. So the negative feedback mechanism which goes to the anterior pituitary does not occur, and thus thyroid TSH secretion is increased. So when TSH is high, we call there is hypofunction of thyroid, that is hypothyroidism. Now there are two conditions in hypothyroidism. Now when TSH is high and free T4 is low, we call it clinical hypothyroidism, that is confirmed hypothyroidism. But there are certain conditions in which TSH may be high but free T4 may be normal. It is usually on the lower range of the normal value or lower side of the normal range. So in that case, we call it subclinical hypothyroidism. Now, subclinical hypothyroidism may need treatment at some places, may not need treatment at most of the places. That is what we can discuss sometime later. Now, let us move to the other part. TSH was high, it was hypothyroidism. Hypothyroidism can be clinical hypothyroidism when thyroid hormone was low, subclinical hypothyroidism when TSH was high in presence of normal T4. Now the another condition, TSH is low. TSH low will occur when there is hyperfunction of thyroid hormone. We are talking all these things in the background that this thyroid pituitary thyroid axis, hypothalamic pituitary thyroid axis is functioning normal. Then what will happen? So when TSH is low, this will occur when there is hyperfunction of thyroid hormone. So there is increased thyroid hormone, which leads to feedback mechanism on the anterior pituitary that leads to suppression of secretion of TSH. So when TSH is low, it means thyroid is hyperfunctional. We call it hyperthyroidism. Now, when TSH is low in combination with high thyroid hormone value, we call it clinical hyperthyroidism. Whereas when TSH is low in combination with normal thyroid hormone, we call it subclinical hyperthyroidism. These values are usually normal, on the upper range of the normal values. Now let us move to the other patterns and let us understand what are the patterns of thyroid function test. First thing, normal functioning thyroid, which means free T4, free T3 and TSH. Everything is within normal range. Now the variations I talked, TSH is decreased with increased in free T4 and free T4 means there is hyperfunctional thyroid, that is hyperthyroidism. When free T4 is less with increase in TSH, this is hypofunctional thyroid, that is hypothyroidism. Now the clinical conditions in which we may have such variations. So hyperthyroidism, that is decreased TSH with increased free T4 and free T3 is seen in Graves' disease, toxic nodular goiter, toxic adenomas, in acute phase of thyroiditis, when there is increase of the thyroid hormone that leading to feedback mechanism decreasing in TSH secretion. Drugs like amiodarone, excess iodine intake, excess thyroxine ingestion, pregnancy related hyperemesis or mole, and congenital hyperthyroidism. These are the conditions in which hyperthyroidism is there with increased thyroid hormone level and decreased TSH level. Now hypothyroidism, increase in TSH with decreased thyroid hormone level that occurs in autoimmune thyroiditis, post radioimmune therapy or thyroidectomy, hypothyroid phase of thyroiditis, certain drugs, iodine deficiency or excess, neck irradiations, Riddle's thyroiditis, thyroid infiltration, and congenital hypothyroidism. Now we will move to variations, that when free T3 and T4 is normal with TSH decreased or TSH increased. I discussed earlier. When thyroid hormone is level are within the normal limit with decrease in TSH, we call it subclinical hyperthyroidism, and it may occur in recent treatment with of hyperthyroidism, certain drugs which include steroid, dopamine, assay interferences, and non-thyroidal illness. The second was subclinical hypothyroidism, in which thyroid hormones were within the normal limit, but TSH was high. So when TSH is high, this shows that thyroid function is decreased. But when thyroid hormones are normal, we call it subclinical hypothyroidism. Now, subclinical hypothyroidism occurs under conditions like poor compliance to thyroxine hormone, malabsorption of thyroxine, certain drugs like amiodarone, assay interferences, non-thyroidal illness, and TSH resistance. We will discuss about TSH resistance also later on. Now, certain other conditions. We do expect when thyroid hormone is decreased, feedback mechanism on the anterior pituitary is decreased, and that would lead to increase in TSH. If this does not happen, that is to say, if thyroid hormone is decreased with TSH within normal value or decrease, so when this will occur? So this happens in non-thyroidal illness, panhypopituitarism, that is to say, when pituitary itself is the focus of the disease, and it is itself not secreting TSH. In that condition, TSH is less, thus thyroid secretion will be less. Isolated TSH deficiency, this is once again defect at the level of pituitary. Then assay interferences and recently treated Graves' disease. So when you treat hyperthyroidism, you give anti-thyroid hormone. Thyroid hormone come to normal range faster, whereas TSH takes its own sweet time, maybe 6 weeks, maybe 8 weeks. So when you start treating Graves' disease, recently treated, early part of the treatment, you may be able to correct the thyroid hormone. Thyroid hormone may come below the reference range, but TSH still remains below the reference range. So recently treated Graves' disease may also have such condition. So when you get such report in your patient, you need to evaluate what actually is happening. Have I treated a Graves' disease and I'm too early, trying to find out what is needed? At times you see the TSH is down, you keep on increasing the anti-thyroid hormone, but here you need to see free T4 and free T3. If free T4 and free T3 is also decreased, you don't need to decrease the anti-thyroid hormone. Rather, you need to decrease the anti-thyroid hormone so that free T3 and free T4 levels come to the normal value, and TSH takes its own time to come within the normal range. Now, another condition. What we do expect when thyroid function is increased, thyroid hormone is increased, it will have negative feedback mechanism on the pituitary and the TSH level should decrease. That is the normal physiology. But if this does not happen, so in the background of increased thyroid hormone level, if we see that TSH is either normal or increased, we need to find out what are the causes. And that this happens at times assay interferences, then thyroxine replacement therapy, particularly when patient has got poor compliance. We all know that TSS takes about 6 weeks to normalize. Patient is hypothyroid. Patient has to come to the doctor, and for past 7 days they have started taking double dose. So TSH has still not normalized. TSH is still in the hypothyroid range, but free T3 and free T4 is high because of increased replacement being done in past 1 week. So thyroid replacement therapy, where compliance is poor, you may have increased thyroid hormone in the background of increased TSH. Then drugs like amiodarone and heparin, non-thyroidal illness, we are going to discuss about it later. Neonatal period, TSH secreting tumor. So central hyperthyroidism, when there is secreting TSH secreting tumor in the pituitary, so TSH is not under the feedback mechanism. There is an independent tumor which keeps on secreting TSH, whatever be the thyroid function. So in the background of increased TSH secretion, increased stimulation of thyroid will occur, and both thyroid hormone and TSH will remain in increased value. Resistance to thyroid hormone, this is I'm going to discuss here also. You will see increased TSH in background of increased thyroid hormones. Disorder in the thyroid hormone receptor and metabolism are the conditions. So these are the patterns in thyroid function test where we need to find out what the causes are. If I say that in today's discussion, this is the most important slide which discusses each and every aspect of the thyroid function. To recap, thyroid hormone normal, TSH hormone normal, it is normal thyroid axis. When thyroid hormone is under the feedback mechanism with pituitary and hypothalamus, with increase in thyroid hormone, TSH level decreases, that is called hyperthyroidism. When thyroid hormone secretion is decreased, that is hypothyroidism, background will be increased TSH. Now, when thyroid hormone is within the normal limit with slight increase or decrease in TSH, we call it subclinical hyperthyroidism or subclinical hypothyroidism. We need to know what are the conditions, and there are certain conditions where these two, thyroid and TSH, goes in the same direction. Usually we have seen when thyroid was increasing, TSH was decreasing. When thyroid was decreasing, TSH was increasing. In subclinical, we did see that this pattern was there, but it was not pronounced. When it goes opposite, we call panhypothyroidism, or there are certain other conditions where this happens. So we move to the next slide. Now we try to understand what are the pitfalls where things go wrong. So it can be pre-laboratory, laboratory, and post-laboratory. Pre-laboratory may include age, pregnancy changes, thyroxine therapy, confounding medications, non-thyroidal illness. Laboratory changes include interferences in assay by different antibodies, and post-laboratory we need to find out if the patient has got thyroid hormone resistance or disorder in the thyroid hormone receptors. So the best way to understand the variations is to take up few cases and try to understand what is happening. I just told you in the beginning, interpretation of thyroid function test is straightforward. Some aberrations occur, we need to correlate it clinically. And to understand it better, we are going to take up few cases and try to understand what is happening. So this is 61-year-old gentleman in ICU, weight 167 centimeter. Weight is 64 kg, height 167 centimeter. He has got type 2 diabetes. He was admitted in ICU with acute inferior MI, and thyroid function test evaluation was done. TSH was low and free T3 was also low. So this looks like, with low TSH, it looks like hyperthyroidism, subclinical hyperthyroidism. So what is this? What we call is euthyroid sick syndrome in this patient. So this is relatively common finding following acute or chronic illness. There is absence of intrinsic abnormality in hypothalamus, pituitary, and thyroid function. Rather, it is considered secondary to adaptive changes. So we should avoid testing thyroid function test in critically ill and hospitalized patient unless it is strongly suspected that patient has got thyroid abnormality. It has been seen that up to 7% of patients admitted in ICU may have TSH values less than 0.1%. In these conditions, pre-illness thyroid function test is invaluable. So if pre-illness thyroid function test was normal, we will consider that this variation has occurred because of acute illness and there is no intrinsic hypothalamo pituitary thyroid dysfunction. Thyroid hormone replacement is not needed in these cases. Follow-up testing is usually necessary. We recapitulate it. Thyroid sick syndrome. This is non-thyroidal illness. It refers to a reduced level of thyroid function blood test found in setting of severe illness in a person without pre-existing thyroid dysfunction. And the rule is that after recovery from severe illness, thyroid function test results usually normalize and there is no need of treatment of this thyroid function. Neither thyroid replacement is needed nor anti-thyroid hormones are needed. Why does this happen? So there is a concept which says that majority of hospitalized patients have low T3 concentration, as do some outpatient who has got illness. And this usually occur because of increased conversion into reverse T3. So when T4 gets converted into T3, certain part gets converted into T3, which is active hormone, and certain part of T4 gets converted into reverse T3. Now this happen, and this reverse T3 is inactive form of the T3. So during non-thyroidal illness, body tries to conserve energy, and that's why amount of T4 being converted to T3 is decreased and reverse T3 is increased. It has been seen that almost 15 to 20% of hospitalized patients and up to 50% of the patients in ICU have low T4 level. And this low T4 level is primarily because of reduction in serum concentration of one or more of the three thyroid binding proteins, which include thyroid binding globulin, transthyretin, and albumin. So what here you see that during acute illness, T4 level is also decreased. TSH levels are also decreased under these conditions. There are certain factors which affects reverse T3 hormone level. Reverse T3 hormone levels are increased, leading to decrease in free T4. They include starvation, heart attack, coronary artery bypass grafting, surgery, bone marrow transplantation. So these are the conditions where you will see abnormal thyroid function test. These are the conditions where you will see euthyroid sick syndrome, and that is what we call non-thyroidal illness, where thyroid function test may be abnormal. Now we move to the second part. Second case. This is 63-year-old man with woman with secondarily progressive multiple sclerosis. She was referred to endocrinologist for markedly elevated thyroid function test. Free T4 more than 100 picogram, free T3 11.6, TSH was less than 0.03. She was on medication 300 milligram of biotin. What it was seen that patient had normal thyroid function test prior to starting biotin, and even at present she didn't have any clinical feature of thyrotoxicosis. The other finding was that her serum vitamin B12 level was also raised in absence of supplementation. What is the explanation? The explanation is that biotin ingested in high dose causes assay interference in thyroid function test and vitamin B12 level. Biotin is water soluble, so it washes out of body quickly, and even a single day can make a big difference in the test. This biotin has got interference by multiple mechanisms depending upon the assay format. So under such conditions, it is always advised that we should remove biotin to minimize the impact on assay interferences. So there are certain methods which include non-biotinated assay, streptobadine, agarose column. So these are used. How biotin affects? So when a biotin is taken, you can see free T4 and free T3 assays increase hugely, and over the time you can see that within 24 hours from the time biotin was ingested, this T3 and T4 comes back to normal. Similar, and this basically happens because thyroglobulin levels are decreased. Due to decreased thyroglobulin levels, free T3 and free T4 are increased when biotin is used. So in this patient, biotin was stopped for 24 hours. Repeat thyroid function test and vitamin B12 were conducted with two different platform assay. They were found to be normal. The patient sample was tested for heterophil antibodies. Heterophil antibodies were also negative. Upon biotin re-challenge, once again, similar abnormalities were noted. So we concluded that this patient did not have any thyroid abnormalities. The abnormality in thyroid function test was basically because of the biotin that patient was getting because of her multiple sclerosis. Now we move to third example. The third example is 24-year-old female with Hashimoto disease, wide fluctuations in her TSH values. Multiple escalation of her thyroid hormone doses led to hospitalization with tachycardia. So what we can see such patients in our cases: hypothyroidism. We keep on increasing the dose of thyroid replacement, and patient is admitted with features of hyperthyroidism. So what happens in these patients? Here you can see that some antibodies were present in that patient. Levothyroxine replacement was reduced based on weight, and free thyroxine level were subsequently used for dose adjustment. In this patient, heterophil antibody interference was responsible. So this may occur into 0.5 to 6% of the patient, where it leads to falsely elevated level of TSH. So here, when you find that you are replacing thyroid hormone, you are continuously increasing the dose, but still TSH is not getting suppressed. Patient starts getting features of hyperthyroidism, you need to think that there is some abnormality or there is some interference in measurement of the TSH, and that is mostly because of human anti-mouse antibody that leads to increased value of TSH. Here you need to discard TSH values or use immunoassay where human anti-mouse antibodies are neutralized, then only consider TSH, otherwise consider free T4 hormone for thyroid replacement. So neutralizing effect of HAMA strategies, there are certain strategies which I'm not going to discuss for benefit of time. There are certain drugs which can lead to alteration of thyroid function test. It is good to recap it. Lithium decreases TSH release, amiodarone, iodine rich drug widely used for management of arrhythmias, which may cause hypo or hyperthyroidism. SSRI, antidepressant, increased TSH, leads to increase in TSH. Estrogen, increased thyroid binding globulin, leads to decrease in free T4. Then androgen and corticosteroid leads to decrease in thyroid binding globulin and increase free T4 level. Now we move to case number 4. 24-year-old female with hypertension was admitted with fracture in neck. Post-op, she developed atrial fibrillation. She was euthyroid. Heparin was given to her, and thyroid function test was evaluated. What we could see that with a normal TSS, that is TSS 3.2, 3.2, free T4 levels were increased, and here heparin is the cause. Heparin leads to increase in free fatty acid concentration, and with free fatty acid concentration, there is increase in free T4 level. Now we move to the last case, case number 5, 69-year-old lady being followed up serially for thyroid longitudinal study. TSH is slightly raised, 5.4, free T4 is less, 29.5, free T4 9.2, anti-TPO antibody is negative, positive. So what did we normally expect? That when there is increase in T3 and T4, TSH should have decreased, but here TSH is increased, and patient has got features of hyperthyroidism. ECG has got atrial fibrillation. So there are two conditions in which this may occur. One is TSH secreting pituitary tumor. So on that tumor, negative feedback mechanism does not work. So TSH keeps on secreting at higher lines, leading to increased thyroid secretion. And the other condition is resistance to thyroid hormone. So when there is central resistance to thyroid hormone, whatever be the amount of thyroid hormone that is released from the thyroid, it is not able to give the negative feedback mechanism which should occur on pituitary. So pituitary does not perceive that thyroid is adequately functioning. So there is no tumor, but TSH keeps on secreting because there is resistance to thyroid hormone. So when resistance to thyroid hormone is there, TSH is usually higher, free T3 and free T4 is also higher, and patient has got features of hyperthyroidism. So these are the two conditions in which you will see such cases. There are certain methods by which you can differentiate these two conditions. In TSH secreting pituitary tumor, usually you will have abnormal MRI with raised sex hormone binding globulin. In resistance to thyroid hormone, usually MRI is normal and sex hormone binding globulins are also normal. A few words about resistance to thyroid hormone. Here, the size of the thyroid gland will increase, so patient will have goiter, palpitation, and resting tachycardia, features of hyperthyroidism. Pituitary thyroid hormone resistance may be there with normal response to peripheral tissues. There may be peripheral thyroid hormone resistance, in which you will see features of hypothyroidism, clinical features of hypothyroidism in the background of increased thyroid hormone level. So in all these conditions, we need to correlate the things clinically. And at the end, I would like to discuss about the discordant thyroid function test, which is when thyroid function is not responding to clinical scenario. I told you, correlate with the clinical scenario. Thyroid function test is usually straightforward. It correlates with the clinical scenario. It correlates with the thing, but there are certain conditions where it may not occur. So try to find out the age, effect of age, neonatal period, elderly. Try to find out the effect of pregnancy. We all know during first trimester of pregnancy, TSH is decreased because of increased HCG level. We know total T3 and T4 is increased because of increased thyroid binding globulin with decrease in free T4 level. So we need to replace usually thyroid hormone in this. Thyroxine therapy early in the treatment, either thyroxine or anti-thyroid treatment. You have to evaluate the things properly. Is thyroid hormone being absorbed adequately, or if there is resistance to that? Then non-thyroidal illness is another thing that you need to find out. Based on these background, you need to reassess if patient has got hypothyroid or if he's euthyroid or hyperthyroid. If still there are certain abnormalities, you need to exclude assay abnormalities, which I discussed a couple of cases, and then you need to exclude genetic or acquired disorders of hypothalamo pituitary thyroid function test. Thank you very much for your patient hearing.
Thank you so much, sir, for such wonderful insight upon the topic that you have shared. And we have received few questions from the viewers. We would like to put it across to you. The first question is, what are the main cause of primary hypothyroidism?
Primary hyperthyroidism. I discussed the causes. Hyperthyroidism included Graves' disease. I mean, usually it is autoimmune mediated disease, primary hyperthyroidism, in which autoimmunes, thyroid, TSH antibodies are there, which leads to autonomous secretion of thyroid function test. Couple of examples I told you, which is Graves' disease is the most common for hyperthyroidism, and Hashimoto's disease is for hypothyroidism, where usually you have anti-TPO antibody positive. So, go ahead.
Thank you so much, sir, for answering the question. We'll move to the next question that we have received. And the question is, what is the role of thyroid binding globulin?
Thyroid binding globulin is the primary protein which binds thyroid hormone in the blood. Certain portion of these thyroid hormone is free, which we call free T3 or free T4, which is usually available for its activity. So when thyroid binding globulins are decreased, it leads to increased proportion of free T3 and free T4. So patient may have feature of hyperthyroidism. When thyroid binding globulins are increased, as in pregnancy, you may have increased total T4, total T3, but free T3 and free T4 may be in normal range or lower range. So if thyroid binding globulin is increased, total T3, T4 is increased, and you will have a conception that probably patient has got hyperthyroidism. But the fact is that free T3 and free T4 may be in normal range or lower, and patient may have hypothyroidism. So there are certain conditions in which thyroglobulin, the primary thyroid binding protein, may be increased and decreased. And in this background, we need to evaluate thyroid function test cautiously, and we should preferably go for free T4 in evaluating thyroid function test. Thank you.
Thank you so much, sir, for answering this question. We'll move to the next question that we have received. And the question is, what is the interpretation of TCH, FT3, FT4?
See, I told you the whole topic I discussed was T3, T4, TSH. The first thing I told you, interpretation is straightforward. In normal functioning thyroid, total T3 to total T4, free T3, free T4 will be in normal range. That will have a feedback mechanism, and that will lead to normal TSH secretion from pituitary. When thyroid is hypofunctional, thyroid hormones, which include T3, T4, both total and free, will be decreased. Thus, there will be decreased feedback mechanism on the pituitary. Then TSH level will be high. That is hypothyroidism. When thyroid is hyperfunctional, it is functioning more than needed, thyroid hormones will be higher. Free T3, free T4 will be higher. That will lead to feedback mechanism on the pituitary, and TSH will be decreased. So when this feedback mechanism is normal, free T3, free T4 moves in direction opposite to TSH. And that is what it defines. It is hyperthyroidism or hypothyroidism. So this is how interpretation of free T3, free T4 and TSH has to be done. Thank you.
Thank you so much, sir. That was the last question for today's session. And I would also like to thank all the viewers who have joined our platform. We hope that the wonderful insights shared by you would definitely help them in their daily clinical practices. So thank you so much, sir, for your valuable insights, and for thank you to all the viewers for their ardent participation. And at the outset,
thank you once again, MedTalk, for giving me this opportunity. Thank you.
Thank you so much, sir. With all your due permission, we are concluding it here today, sir.
Yeah. Bye-bye.
Bye, sir.